Dr. Lau, thanks so much for being here. Everyone, Dr. Chelsea Lau is a second-year Hematology Oncology Fellow at Northwestern's Robert Lurie Comprehensive Cancer Center. She completed her medical school and residency, including chief residency, in the University of Virginia Medical Center prior to joining the Hematology Oncology program at Northwestern, where she participated in quality improvement in multidisciplinary care of cystic fibrosis under the mentorship of Dr. Dana Albon. She is currently a trainee under the Northwestern University Translational Research in Hematology and Oncology NIH T32 training grant, and her primary research involves investigating the impact of underlying conditions on risks of immunotoxicity in thoracic, oh gosh, genitourinary and cutaneous malignancies. She plans to pursue a career as an academic oncologist and clinical investigator after completing her fellowship training. Dr. Lyle, thank you so much for being here.
Oh, wow, that was, like, so official. Thank you so much, Devin, I appreciate that. Okay, here, let me hide this before I get confused. Okay, so thank you so much for that introduction, Siri. Also, I was so grateful that I had the opportunity to be, and still do, a part of the Patrick Nash training program, so I'm really grateful to be here. As I said, I'm gonna get into some weeds, biologically speaking, here today. So if there's at any point somebody has like a question or confusion, feel free to like raise your hand. There will be time dedicated at the end for questions, but I want to make sure things are clear. So feel free to do a little hand emoji or send something in the chat. And if I don't see it, feel free to unmute yourself and say, "Hey, I had a question." So today I'm going to be talking about navigating and understanding cancer risk and cystic fibrosis. So how can we be aware of this? How can we prevent it? And then what do we do once it happens? So I'm going to go over some of the biology of cancer development, which is going to be really important as we start to talk about how the CFTR protein and gene play a role in cancer development. We're going to talk about what cancers patients with cystic fibrosis are at an increased risk for, what the recommendations are for screening, and then what do we need to think about as we're treating cancer and cystic fibrosis, and what can kind of you guys think about if hopefully this is never something you have to think about, but if so, what are the things that you want to be bringing to your providers? So some of this is going to take us back to high school biology a little bit, but this is a cell cycle. If any of you have traumatic memories of this, I apologize. I know I do, but um, essentially, cells divide to replace and repair organs in the human body. This is a natural process, it's necessary, and it is incredibly tightly regulated because, as you can imagine, if something happens with this, if it goes wrong, there can be really serious consequences like cancer. So, as a cell goes through its life cycle, there's multiple points in the cycle to check, should we keep going forward? Should we proceed? So we call these checkpoints. So there's a cell growth checkpoint. This cell growth checkpoint is also kind of the do we want to start the process of dividing at all checkpoint. There's a DNA replication checkpoint. So this says like, hey, did we copy everything right? Are there any errors here? Is there anything we need to fix? Then there's a chromosome division checkpoint. Because if you guys remember, all of those have to line up in the middle of the cell and divide equally to make two identical copies of the cell. And if there's a problem in that, then it should stop, it shouldn't move forward. So division can be halted at any point along the cell cycle, particularly at these checkpoints, if there's any problems or if the cell should otherwise not divide. Like if it's a cell that shouldn't divide, a lot of our neurons in our brain should not do that anymore. They're good, they're done. They shouldn't divide anymore. So we've got mechanisms in place to keep them from doing that. Other cells, like our skin, dividing really, really frequently. So it's even more important that when we have DNA that replicates and those chromosomes that divide, that we're really making sure there's no errors before we move forward. So when it comes to what happens if something goes wrong, so cells can get damaged during their life cycle. So I mentioned skin, right? We all know about sunburn can cause damage to cells, can also cause damage to their genetic information. If that happens, then we want to try to fix it. So a cell has some mechanisms to repair errors in their genes that are caused by damage. Sometimes all those errors get repaired and the cell is happy and it moves forward and there's no problems. But sometimes those cells have errors that stick around, and then there's more errors, and it can't fix them. So the mechanisms to repair these changes aren't working. So then the cell has instructions to essentially kill itself, to be done. It's like, okay, I can't fix this. I am a broken cog in this particular machine, and I need to go away so that something else can take my place. And so we call this apoptosis. And apoptosis is a natural process of where the cell programs itself to die, and that keeps damaged cells from dividing and multiplying, which, as you can imagine, becomes really, really important as we're talking about cancer. So, there are some specialized genes that control this main process. So, cell division, repair, and then the apoptosis. So, I'm going to talk about a couple that are really important as we're talking particularly about cancer and cystic fibrosis. The most important ones here are these tumor suppressor genes. So, I want you to think about these as brakes on a car. So, if a car is moving towards something that it should not go towards, in this particular figure, it's cancer. But like if you're driving and you're about to hit a tree, you're going to want to stop, right? So, a tumor suppressor gene is the brakes. It prevents the cells from dividing inappropriately. But there's also things on the other side of the spectrum that's more like kind of putting a brick on the gas pedal. We call these oncogenes. So if these are turned on, then there's uncontrolled motion forward. There's uncontrolled cell division moving forward. And so if you're headed towards a tree and you put a brick on the gas pedal, it can be very bad because you will run much faster into the tree. Now, with that being said, let's say that you've got a brick on the gas pedal but functioning brakes. If you put your foot really hard on those brakes, you can probably still stop the car, right? You're going to hear some unfortunate gear stripping, but you're going to probably stop the car. If your brakes don't work, but nobody's pushing on the gas pedal, then you're also not going to move forward. So you really need to have errors in a couple of these things before things head in the wrong direction. So we're going to talk about this is just an example of a tumor suppressor gene. So P53 is a very commonly described tumor suppressor gene. It's really cool because if there's damage to a cell, P53 says to the cell, hey, stop what you're doing, fix it or die. So it says either you stop this cell cycle, you stop dividing, you fix the error, and then you can start again. Or if you can't do that, then I'm going to start this process that says that you're going to undergo apoptosis. Now, if it changes, if P53 doesn't function anymore, if this tumor suppressor doesn't work, then a damaged cell doesn't get that signal. It doesn't get the signal that says do not pass go, do not collect $200, do not divide. So it moves forward and it continues to divide, and those cells can then become cancerous. So as I mentioned, we've got a lot of these checks and balances to prevent inappropriate cell division. So it's a little more complicated than one brake and one gas pedal. There's more like a bunch of each. Usually one change isn't enough to cause cancer. So cancers, for a cell to turn cancerous, you're going to need multiple genes to be damaged or changed. So the tumor suppressor genes or negative cell regulators are turned off. So that's kind of the first thing in this diagram here. So we've got an initial mutation that turns off a tumor suppressor. Then our next mutation maybe turns on an oncogene. So we've broken the brakes and now we've dropped a brick on the gas pedal. There's another kind of mutation that we haven't talked about yet, which is essentially we have a lot of mechanisms to make sure that our DNA replication is perfect and that if there's any errors that they get fixed right away during DNA replication. And once a cell starts dividing a lot more frequently because you've turned off the tumor suppressor and you've turned on the oncogene, so you've got no brakes and the gas pedal's on, then you're going to have a lot more of these cycles. There's going to be a lot more opportunities for errors to happen. And then if there is an error in one of those cycles that makes it so that you can't proofread your DNA anymore, then every time you undergo a cell cycle and a division, you're going to get more and more changes. And so these gene changes that promote further gene changes increase the chance of the cell becoming cancerous. So it's just kind of like a runaway truck at this point. So this diagram, I don't want you to focus too much on the words on it, okay? Because the words are too much even for me. But Once a cell is cancerous or precancerous, it starts to accumulate these changes, and these changes help it to grow, help it to escape our immune system, and help it to spread throughout the body. Um, so as a cancer cell gets more and more changes, as it gets more errors in its DNA, it starts to look less like what it started as. So cells that have a function, that have a job, like they're doing that job. So like skin cell looks like a skin cell usually. A stomach lining cell looks like a stomach lining cell because they have a function. They need to look a certain way. But as a cell starts to get more changes, it starts to look less like what it's supposed to be. We call this process de-differentiation. This is important because the less differentiated a cancer cell is, the more aggressive it is. And by aggressive, I mean not only it's dividing faster, so a tumor is growing faster, but it's also more likely to spread and go somewhere else that it's not supposed to be. So remembering like undifferentiated with cancer is really bad. And if there's something that makes something undifferentiated, it's probably going to cause a problem. So this brings us to what the heck does CFTR have to do with any of this? This is a chloride channel. Like, why is this even a part of our cell division? Like, I don't understand. But we've done a lot of work on this, and it's actually crucial. So, CFTR dysfunction in cancer has been implicated in cancer risk, development, and progression in multiple studies. It's actually identified as a tumor suppressor at this point. So we think about CFTR as one of the braking mechanisms. So if CFTR isn't working, or if someone has two copies that already don't work at the beginning, then you come into it with broken brakes in this particular circumstance. Like I said, we have other brakes, so it doesn't mean that immediately everything goes out of control, but it's one thing that you start off with where you're already at risk. And there's a few other mechanisms by which it can affect cancer. So not just this kind of tumor suppressor effect, but other ways that it interacts with its environment. So
Hey,
we know
we
the
have a question in the chat.
Yeah,
Why do CFTR error cells still divide successfully?
yeah. So like I said, we've got kind of multiple checks and balances. And the CFTR, the way that it's a tumor suppressor, is a little bit different from like P53, where like um, it's kind of really, really deeply intrinsic to the process. The other thing is that remember with the tumor suppressor, if it's not functioning, it's not that you can't divide, it's just that if there's something that normally would stop division, then like if normally you would have an error and CFTR would stop division, that it doesn't do that. So the division process itself isn't hindered here. It's what happens if there's an error, if there's a mistake. Um, so we know the most about CFTR function in colon cancer because, as we'll talk about later, colon cancer is one of the things that we're most concerned about in patients with CF. It's the highest risk. So one of the things we know that CFTR does and CFTR mutations can do is that patients with cystic fibrosis have changes in their microbiome. And that's for a lot of reasons. We're going to talk about that in a little bit. And it's not just the function of it itself, but that can increase the cancer risk, changing the microbiome. You can have inflammation in your gut because of the changes in the microbiome, because of the thickened mucus, and that inflammation can cause cell damage. So I talked about earlier where we've got cell damage that can lead to changes in the genetic code. We also know that CFTR changes how acidic it is inside and outside of a cell, and that can promote tumor growth. I'm going through all of these in detail in just a little bit, but this is just kind of an overview. It also doesn't exist in a vacuum. So it interacts with other proteins that are important for interpreting DNA instructions. So when it's dysfunctional, if there's something else that happens, if there's an additional stress, sometimes that can lead to changes in cell cycle and function. So when it comes to the microbiome and CFTR, this is something I'm sure that I don't really need to explain to most of you. You've probably heard about this a lot, but taking antibiotics for pulmonary exacerbations, taking acid suppressing medications to deal with reflux, having impairments in your ability of your pancreas to function normally, all of that leads to changes in the composition of the bacteria in your gut. And bacteria in our gut is supposed to be there. It's a symbiotic relationship. We need it. But when it changes, we have these changes in cystic fibrosis, it can lead to intestinal inflammation. Um, and so this increased inflammation and the changes in the bacterial makeup itself can make a microenvironment. So this is a word I'm going to explain more in a minute, but an environment around those cells that is more tumor friendly. So tumor microenvironment is just what it sounds like. It's the area immediately around a tumor. And it's really important for that tumor because the tumor doesn't exist in isolation, right? It's inside your body. It's surrounded by things. It's surrounded by blood vessels, by other tissues, by fluid, by immune cells. And in order for a tumor to thrive and grow, it needs a microenvironment that is conducive to that. And so a lot of research in cancer lately has been thinking about this microenvironment. And patients with cystic fibrosis and who have dysfunctional CFTR have some changes that can promote a tumor-friendly microenvironment. So one of those things is inflammation. So I mentioned this already. Inflammation is a massive term. It means a lot of things, but essentially it's um, an inappropriate release of markers that are inflammatory in a particular location, and inappropriate activation of the immune system, certain parts of the immune system that can lead to damage in a particular area. Acute inflammation, less of an issue than chronic. So something that's there for a long time that's causing recurrent ongoing cell damage. So we know that there's chronic inflammation in the gut in patients who have cystic fibrosis because of the dysfunctional CFTR. So this chronic inflammation leads to this recurrent cell damage, these genetic mutations. This can promote de-differentiation. So I mentioned this earlier, right? The cell stops looking like what it's supposed to look like. It de-differentiates. That increases the risk for tumor formation. This chronic inflammation also changes the tumor microenvironment. So immune cells become suppressed actually in chronic inflammation in some areas. So the tumors get less exposed to the immune system. Immune systems are important for protecting you from cancer. They find early cancer cells, they destroy them. So if a tumor has managed to protect itself from that, then it's more likely to survive. These markers of inflammation that I mentioned, these things called cytokines, that is just essentially they're molecules that are released with inflammation, they can actually promote tumor growth. The other thing is that as a tumor grows, it kind of outruns its blood supply. And in order for it to continue to grow, it has to find a way to make new blood vessels. And these new blood vessels, it's called angiogenesis, growing them is actually promoted by specific changes in the tumor microenvironment. You cannot make them without the microenvironment being favorable. The other thing is that these changes can actually make cells more likely to move and metastasize. We can talk about exactly how in a little bit. And metastasize just means going from where it starts, going to other parts of the body. And that can be really scary in cancer because once cancer moves throughout the body, it's not, we can't really cure it anymore. So as all of these things are happening in the tumor microenvironment, it really matters for what's happening with the cancer. So CFTR, in addition to kind of this global increase in inflammation, the change in the microbiome, um, it also actually directly, just as a chloride channel, affects the tumor microenvironment. So normal cells are supposed to be a little bit more acidic inside than they are outside. But when CFTR is dysfunctional, it actually reverses that. So you end up with a more acidic environment outside of the cell and a less acidic environment inside of the cell. And this is one of the things that's really important for making those blood vessels. So an acidic environment promotes blood vessel growth in tumors. And then it's also important for metastasis. So an acidic environment can promote metastasis. So this is one of the ways that the direct dysfunction of CFTR actually impacts cancer development. We also know that CFTR is important for cells to essentially regenerate and grow back after an injury. So when it works normally, it's interacting with proteins that are important in cell division and differentiation. So you get this beautiful growth from basal cells that then become this, if you move all the way over to the right, those like kind of hairy cells at the end, those are totally functional, fully differentiated cells that are doing their job at the top, all the way over to the right for A. But for cells that don't have functioning CFTR, these cells don't reach that functional state or differentiated state as quickly. So they're more likely to stay undifferentiated. So that's one of those buzzwords we mentioned before, where when cells are undifferentiated, they'll grow when they're not supposed to. A specific step that I want to talk about that's important for cancer specifically is called EMT, epithelial to mesenchymal transition. Don't need to remember that part. Just think about it as a type of dedifferentiation. So these cells go from looking like these beautifully organized, tied together square cells that have this beautiful function to kind of mush. they just, they have, they are not attached to each other anymore. They don't have a specific shape. They are these kind of less differentiated cells. And we know that CFTR is important to protect against that. So this diagram is really scary. So I don't want you to look too much at like the small details in the middle. Just remember that all the way to the left is what the cell is supposed to look like, and all the way to the right is what the cell looks like after it's done this transition. When CFTR is working, it protects the cell from undergoing that transition when it's not supposed to. But when CFTR isn't working correctly, damage to the cell can make it more likely for it to start to look like those undifferentiated cells. So, all of this leads to an increased risk of cancer and cystic fibrosis. So, we know that not just the inflammation that happens because um, of recurrent infections and hospitalizations, but also down to the molecular level, the CFTR, that protein, actually is important in helping prevent the development of malignancy. And when it's not functional, that can promote the development of malignancy. So these are the cancers that we know there is an increased risk for in cystic fibrosis. So particularly colorectal cancer and intestinal cancers. So there's actually 5 to up to 10% increased risk in cystic fibrosis, and these cases tend to happen earlier. So not just that you're more likely to develop cancer or this colorectal cancer, but patients with CF can be diagnosed with it at younger ages. Pancreatic cancer is not as common as colorectal cancer in general, so we don't see it as often, but the relative risk is just as high. So we start off with a smaller number of people who are at risk for it in anyway, but so we don't see it as frequently even when the risk gets higher, but it is much higher in patients with CF. Some of the other tumors that can be seen more frequently, but maybe not quite as profound, things like liver cancer, testicular cancer, cervical cancer. There's also some debating evidence that esophageal and gastric cancers are more likely as well. What's really interesting with lung cancer, and we're going to talk about this in a little bit more detail, is that we don't really know if it's an increased risk or not, because there's a lot of conflicting data about it. So I have a particular interest in lung cancer, so this is one of the things that I really want to think about. But from a global perspective for patients, yes, Devin?
Sorry to interrupt. I was just wondering, how do we differentiate cancers caused by CFTR dysfunction versus cancers caused by, I don't know, something in one of our medications?
So that's an excellent question. And one of the short answers is it's definitely a confounding factor. So like if there are like um it could definitely there medications that could contribute to this, particularly in combination, and we just don't know that. But we don't see those medications in other populations causing the same risk. So when it comes to medications like CFTR modulators, and be honest with you, we don't have enough data right now. It is too early. We have not had them long enough to know if they are having an effect, positive or negative, on cancer risk. We just don't know. But when it comes to some of the other medications, like a lot of the antibiotics, like inhaled saline, things that are not as specific to the CF population, but are used very frequently in the CF population, because we are able to study them in the broader population, we know that they are not generally associated with an increased risk of cancer. I honestly don't know about pulmazine. but I have not read any studies that associate it with increased risk. So that's maybe something that I can look into as well. But because of all the reasons that I said before, with investigating CFTR specifically, we know that that does increase cancer risk from a mechanistic perspective, as well as from an observational or population level perspective. So the short answer is probably confounded. There may be contributions from medications as well, but we know that cystic fibrosis itself and the genetic changes itself increase that risk. The other thing that we know is that more severe CFTR mutations, so mutations that cause worse dysfunction or total dysfunction, are associated with a stepwise risk of cancer, at least colorectal cancer. So more severe mutations are associated with more severe cancer. And so all of that kind of leads us to think that the issue is more with the underlying protein function and gene changes than with the management. That's a great question.
Julie
So
also has another question in the chat related.
yes.
Oh shoot, it just left. Do you see an increased risk in these cancers in heterozygotes? Julie, do you
Yes, and
mean
I'm
like someone who has a Delta 508 and another mutation?
I mean, carriers.
Okay.
carriers.
Yeah.
So I'm going to talk about that. The short answer is yes. Um, but yes, but I'm going to talk about that a little bit more. I'm sorry, for some reason chat is not coming up, so feel free to continue interrupting, like letting me
Oh
know
yeah,
because if I don't see
absolutely.
it.
Yeah. And
Okay,
I love asking questions. I just don't want to only ask my own.
no, it's great.
Thank
Um,
you.
okay, so where was I? Here. So colorectal cancer. So this is a kind of a graphical manifestation of the increased risk of colon cancer in patients with cystic fibrosis as compared to the general population. So the CFF registry, Cystic Fibrosis Foundation Registry, reports patients who are diagnosed with cystic fibrosis by age, and you can see that um, the age-specific rate per 100,000 goes up earlier and gets a lot higher than with the SEER registry, which is essentially a US general population-wide registry. So we know that patients who have cystic fibrosis are anywhere from 6 to 10 times more likely to develop colorectal cancer. We also know, so colonoscopies of patients with cystic fibrosis have shown larger and more aggressive polyps as compared to age-matched individuals with cystic fibrosis. So we can see this process happening kind of in real time. We see these precancerous lesions that are more common as well. So by age 40, about half of patients with cystic fibrosis will already have developed a type of potentially precancerous polyp called an adenoma. Half of these are highly aggressive adenomas, so considered to be pretty likely to develop into cancer at some point. Now, good news is you get a colonoscopy, they take these out, and then they don't become cancer, right? But to see them, to see half the patients by age 40 is pretty startling. And then by age 40, 3% of patients with cystic fibrosis will already have colon cancer. So it seems like a pretty small number, but it's much higher than we would expect in the general population. So we actually now consider this a hereditary colon cancer syndrome. So there's other hereditary colon cancer syndromes, like I don't know if you guys have ever heard of Lynch syndrome, or there's a couple of other familial syndromes where essentially they're diagnosed because a bunch of people in their family end up having colon cancer. And we watch these patients once we've identified a family who has that risk factor very, very closely. They get colonoscopies more frequently, they get them earlier. Some patients who have these hereditary colon cancer syndromes have such high risk they actually undergo prophylactic colectomies at certain ages. We're not there for cystic fibrosis, but we do watch much more closely. When it comes to pancreatic cancer and cystic
Oh, sorry to
fibrosis,
interrupt. We have another
yeah,
question from the chat.
yeah.
This person asks, I know hormones have correlations with some other cancers. Do you know if there's any evidence that hormones play any role within colon cancer and CF?
So not specifically in CF. Um, there are some colon cancers that may be responsive to hormones, but it's not typical. It's not all of them. There are other cancers where hormones are much more much more active. So things like prostate cancer, breast cancer, testicular cancer, ovarian cancer. Um, we, with the exception of testicular cancer, we don't see those at a higher rate in cystic fibrosis right now. But as we'll discuss in a little bit, that could change as the population gets older. So as patients with cystic fibrosis increasingly reach their 50s, 60s, 70s, it's possible that we may start to see some changes in the relative risk for some of these other cancers that tend to be seen in older individuals, like breast and prostate. And those are much more impacted by hormones. Um, but I don't think colon cancer quite as much. Does that
Thank you
answer the
so
question?
much. Yeah.
Yeah, of course. Okay. So pancreatic cancer, like I said, much less of a risk to start off with, but 5 to 10 times as likely is pretty scary for a cancer that is highly aggressive and highly fatal. So pancreatic cancer barely makes the top 10 for incidence, and it's the third killer of people in the country by cancer. So after breast and lung, then it's pancreatic cancer. So it's a really scary cancer, and it's one that we take very seriously. We know that in cystic fibrosis, or we think in cystic fibrosis, that increased chronic inflammation, changes in bile flow, and increased oxidative stress all contribute to increased risk. So we know inflammation, oxidative stress cause cell damage causes DNA damage leads to cancer, right? When pancreatic cancer is operable, this is like the best case scenario, is when it can be removed from the body by surgery. And for patients with cystic fibrosis as compared to the general population, survival is about the same if the cancer is resectable. Once we get to inoperable or unresectable cancers, there is some evidence that there's a worse survival in cystic fibrosis as compared to the general population. The hazard ratio is not super high here. So hazard ratios are like, what's the percentage above, or what's the increased likelihood of an adverse outcome based on this particular variable. And so 1.17 is like a 17% increase in like risk of bad outcome. But the curves you can see there, the green line is how, like, as it goes down, as the line goes down, that's like something bad happened. So each time you see that little line like take a step down, that's a person that died. Um, and the green line is patients who do not have cystic fibrosis but have cancer. And then the purple line is patients who do have cystic fibrosis and have cancer. And you can see that the step downs start to happen more frequently at an earlier time point for patients with cystic fibrosis. In terms of why this might happen, it could be some of the things we already talked about. So we know that when CFTR is not functioning well, that there's an increased risk of metastatic spread, there's an increased risk of dedifferentiation, increased risk of tumor aggressiveness. So we have seen this in patients with cystic fibrosis who are diagnosed with pancreatic cancer, that their tumors behave more aggressively. Liver cancer, the risk increase is not that much higher as compared to the general population. This usually depends on how much liver dysfunction there is, but it's not fully dependent on that. So we actually do see an increased risk of liver cancer regardless of liver dysfunction. We think this is because of changes in bile flow that lead to fibrosis in the liver and increased inflammation. We also know that CFTR is important for liver regeneration. So I mentioned CFTR, we need it to make cells recover from injury appropriately, right? It's important for that injury recovery process. So if you have impaired CFTR or dysfunctional CFTR, then your liver isn't going to heal as well, it's more likely to scar. And when you get liver scarring and a lot of liver scarring, that leads to a condition called cirrhosis. So cirrhosis is essentially just bad scarring of the liver for a bunch of different reasons. It can be because of alcohol use, it can be because of non-alcoholic fatty liver disease, but it can also be because of other underlying genetic conditions or cystic fibrosis. Now, as I mentioned, lung cancer is an interesting case because you would think I've talked about like how inflammation, changes in bacteria, all of that is like it's a breeding ground for cancer. It's just laying the groundwork for it. We don't actually see like in a widespread fashion, an increased risk of lung cancer in patients with cystic fibrosis. There are some case series where we see maybe more cases than we would expect, but overall, we don't really see an increased risk for most kinds of lung cancer. Um, there are some specific kinds of lung cancer, like bronchial carcinomas, that are seen at a higher rate in patients with cystic fibrosis than in the general population. And we also know that patients with cystic fibrosis who smoke have an even higher risk of cancer than smokers who don't have cystic fibrosis. But it's possible that the population who has cystic fibrosis don't tend to smoke. Like it's a population that's not smoking all the time, right? Like guys really take care of your lungs. And so that could contribute to why we actually don't necessarily see an increased risk in this population. Now, like I said, with breast cancer, prostate cancer, this could change in the future. So as we see patients get older, that's a population that's more likely to have lung cancer in general. That might be when we start to see a change in the risk, but right now we don't really. So we're kind of watching this more closely. It's something I'm particularly interested in. I want to know if we need to be screening patients with cystic fibrosis who don't smoke versus patients who do, but right now there's no indication that we need to do that. Cervical cancer really becomes more of a risk in patients who've had a lung transplant. So higher rates of high-risk HPV and higher rates of cervical dysplasia. So dysplasia is just another word for undifferentiated or cells that don't look like they're supposed to, are seen in patients who have cystic fibrosis that have a cervix and have undergone a lung transplant. So we know that if you have a transplant and you're on immune suppression, that changes your body's ability to clear infections. You might be more likely to develop problems after you get an HPV infection. What's interesting is that there's actually higher rates of abnormal cervical cytology in patients with CF who did not have a transplant, despite a high-risk HPV prevalence that was pretty similar to the overall population. So when it comes to transplant patients, probably an inability to clear HPV or a likelihood of HPV reactivating is driving the increased risk. And patients who haven't had lung transplants, there might still be an increased risk because of some of the things we've mentioned for other body parts. So we know that cervical mucus is different in patients who have cystic fibrosis, particularly those who aren't on CFTR modulators, could lead to increased inflammation in that area, lead to changes in cervical cytology. So after lung transplant, I mentioned this for cervical cancer, but what about for other cancers? So we know that in general, once you've had a lung transplant, you're at higher risk for cancer because the immune system is really important for controlling cancer, keeping it from causing problems. And once you suppress the immune system to protect a transplant, you're opening the door for cancers to come about. This diagram is actually comparing patients with cystic fibrosis who got a lung transplant compared to patients who got a lung transplant for other reasons. And there are certain cancers that remain at higher risk in patient or that are at even higher risk for patients with CF who undergo a lung transplant compared to those who undergo transplant for other reasons. Some of these are ones we already know about, right? Esophageal and small intestinal cancer or gut or colorectal cancer. Those are things we already have on our radar, right? We know that there's an increased risk in patients with CF already. And then when you suppress their immune system, obviously it makes sense that that would go up even higher. But we also see an increased risk for lymphoma. So for a non-Hodgkin lymphoma. And this could have to do with changes in how cystic fibrosis patients handle a type of infection that tends to cause this called EBV. It's the monovirus, but that can increase your risk for lymphoma. So we do have some different screening recommendations for cancer that differ between patients who have cystic fibrosis who've had a lung transplant as compared to those who haven't. So here I'm talking about cancer risk for carriers. So we have a couple of population-based studies that show that there is an increased risk of cancer in heterozygotes for a CFTR gene mutation. And this also, we think, correlates with severity of that gene mutation. So more severe gene mutations, higher risk than less severe gene mutations, even in a heterozygote. And so there's about a 44% increase in the risk of GI cancers. So as opposed to the like 500% increase, right? 5 times that we see in patients who actually have cystic fibrosis. This is not reaching that levels, but it is still statistically significant. We also found an increased risk of esophageal cancer in a separate study, but these other trends were not statistically significant. So we don't see that there's a lot. So the most important thing to get out of this whole talk, if you have not listened to any of the other things that I have said, which is totally fine, but this is the thing to pay attention to. So colon cancer is a huge risk. When it comes to patients who don't have CF, screening starts at 45. This was just dropped from 50 because colon cancer is going up in everybody that's young between ages of 40 and 49. When it comes to patients who don't have cystic fibrosis, there's a bunch of testing options that can be at various times, but colonoscopy is considered gold standard because it allows removal of those precancerous polyps. When it comes to cystic fibrosis, the CF Foundation has made a very strong recommendation for colonoscopy only as the screening technique because it allows for removal of precancerous polyps. That should start by at least age 40 in patients who do not have a history of a lung transplant. In some other countries, that age limit is, or that age to start is actually lower. It's actually 30. And there are some providers in the US who also recommend starting at a younger age because we do see patients being diagnosed with colon cancer, even advanced colon cancer in their 30s who have CF. For patients who had a lung transplant, it's 30 for sure. Like if you are 30 and you've had a lung transplant, if you haven't had a negative colonoscopy within the past 5 years, you get a colonoscopy as soon as you recover from surgery. If you have had one within the last 5 years, you still need one within 2 years of transplant, and then at least every 5 years after. If they find anything, then it's every 3 years. So that interval is shorter for patients with CF as compared to the general population because the risk is so much higher. In terms of why you want to do this, so colonoscopy in the general population has been associated with an almost 70% decrease in the diagnosis of colon cancer because it gets rid of those polyps before they become cancer, and an almost 90% reduced risk of mortality because screening allows detection of colon cancer at a younger or at an earlier stage. An earlier stage disease has better overall survival. So if you look at a stage 1 colon cancer, that's that blue line at the top. So this is kind of similar to the other plots we were looking at, where as the line comes down, that's an indication of a lower survival probability as you move through time. We call this a Kaplan-Meier curve. So you can march right down. Stage 1, that blue line stays up at the top for a really long time. Red line stays pretty near the top for a while. But as you get to stage 3 and stage 4, that survival probability as you go out from diagnosis starts to go down pretty quickly. So you want to diagnose these much earlier. When it comes to other cancers, there's no CF specific recommendations, just because there's either lower evidence for increased risk, or if we know it has an increased risk, we don't have great screening methods. So we recommend that you follow the USPSTF guidelines for breast cancer screening for people with breasts between ages 40 to 74. For those who have dense breasts, sometimes we'll use ultrasound and MRI too, but there's not actually enough data to recommend that right now. We also know that early diagnosis of breast cancer improves survival. So really important to be getting those mammograms as soon as you get to 40 or younger if you have a family history. Cervical cancer, start with a pap smear starting at age 21. Before that, you're going to maybe see changes that don't actually mean anything. So 21 is really the age to start. And then there's a couple of different options for how you do that change based on age. One of the things to remember when you're going to see your gynecologist, co-testing is really, really common. It has a higher sensitivity than HPV testing alone. So it's less likely to have a false negative, but you can have more false positive rates. So just something to discuss with your provider if you're curious about which one is the best for you. Some cystic fibrosis experts have recommended considering screening for other GI cancers, particularly things like pancreatic cancer or biliary tract cancer, which we didn't discuss, but is essentially cancer of the ducts that go from your liver to your gut. Because those are such high morbidity and mortality cancers. So we don't have great screening tools, honestly, for these cancers in the general population. The the tools that we have, like MRI, we also call MRCP, MRI and MRCP, are very expensive scans that tend to find a lot of things that don't mean anything and can lead to biopsies that cause more harm than they help. And so we were really cautious about implementing those on a large scale, not only because of cost relevance, but also because of potential for harm. Because if you undergo a biopsy that you don't need, you are putting yourself at risk of that needle hitting something it's not supposed to and having something bad happen. But with the higher risk in cystic fibrosis patients, it's possible that the balance of the risk of those screening methods as compared to the benefits might be altered. But that's not something that we're going to know until we try to implement it because um, it's really going to need to be like looking at the population saying, okay, if we're screening like 10,000 patients every year, because these MRCPs have to be pretty frequent, like every year for transplanted patients, every couple of years for non-transplanted patients. Like, what does the cost of that look like? How often are we having biopsies that people don't need before we say this makes sense to do? So I think that this is really kind of a future direction and something that we should think about moving forward. When it comes to management, um, some of the things that matter for patients with cystic fibrosis, it depends on lung function. So surgical resection is really important for early stage cancers. We want to be able to remove these, but some of these surgeries are really intense on the body. And if they have severe lung disease, sometimes they might be determined too high risk for some kinds of resections, which then could limit treatment options. Hopefully, as lung functions continue to improve with widespread use of CFTR modulators, this is going to become less of an issue, but it is something to think about. When it comes to medical management, we want to make sure to avoid anything that has a lot of pulmonary toxicity for obvious reasons. For colon cancer, we don't have, honestly, a lot of medications that cause that problem, but for other cancers, it's a massive list. So this is for breast cancer to the right. There's a lot of medications that have possibility for bad pulmonary toxicity. We want to think really carefully before we use those in patients with cystic fibrosis. So it's going to be shared decision making. It's going to be something that like either the patient needs to bring up with their physician or the physician needs to ensure that they discuss with their patient to make sure that the risk is fully understood before starting those kinds of treatments. There's also some chemotherapies that could worsen adverse effects that patients with CF already experience from their treatment. So hearing loss, huge problem in the cystic fibrosis community, and there are some chemotherapies that are pretty commonly used that can also exacerbate hearing loss. So for a cancer provider who isn't aware of that, who isn't aware of the issues with hearing loss in the CF population, that's going to be something that needs to be brought up and thought about. We also know that CFTR modulators interact with some anti-cancer therapies, so we need to watch those drug levels or maybe choose different therapies. This is just kind of a throwaway interesting thing. There's actually some chemo drugs that they considered using as CF treatment a long time ago because they're actually associated with upregulation of CFTR and improved pulmonary function. So there's a particular chemotherapy called doxorubicin, which sucks deeply. It's the worst ever. But if patients who have to get it for cancer for other reasons, they actually will have improvement in their pulmonary function while they're getting it. So not all doom and gloom. There's some unexpected silver linings here. We also want to make sure that patients who have cystic fibrosis have really good nutrition. We know that cancer-related malnutrition has a ton of potential adverse outcomes in cancer management. Luckily, for those who can get CFTR modulators, nutrition has improved a lot in patients with cystic fibrosis. But for patients who aren't candidates, we really want to be working closely with nutritional experts in CF to help manage some of the adverse impacts there. So I want to leave a little bit of time for questions at the end. So I'm sorry I'm rushing through these last few slides. This is actually CFRI beautiful graphic that I stole without crediting, so I'm going to credit verbally. But as the life expectancy for patients with CF goes up, we're going to see more cancers. It is just mathematical, right? Risk for cancer goes up as people get older. As the population gets older in cystic fibrosis, we're going to see more cancers. We already have an 11% cause of 11% of patients who died with cystic fibrosis in 2023 died from cancer. And we see an ongoing increase in cancer in non-transplanted patients. For patients who do have a transplant, the median time to the first instance of the cancer is 4 years, which is like zero time. So for patients who have transplants, we really need to be thinking about this. We know that colon cancer is at higher rates in patients with cystic fibrosis compared to the general population, potentially because of inflammation, changes in the tumor microenvironment, and then interactions between CFTR and other proteins. We want to make sure that patients who have CF are getting earlier colorectal cancer screening with colonoscopy, but don't forget your other cancers. You want to be staying on top of cancer screening guidelines across the board because that risk doesn't go away for those cancers. It's possible that we're going to change our screening recommendations as we move forward in time, as patients get older and we see more cancers. Or for these cancers where we don't have great screening methods, maybe it's time we figure some out for patients who are at such high risk. The last thing I want to emphasize is that cancer and cystic fibrosis should not be a one-man shop. This has to be a multidisciplinary discussion. It has to be oncologists working really closely with cystic fibrosis specialists, because I guarantee you that most oncologists will not have specialized training in cystic fibrosis. And I know that cystic fibrosis patients are amazing advocates for themselves and that you guys are insanely on top of all of the things in your lives, but this should not be your responsibility. This should be the coordination of care between providers. And so it is my hope as we move forward, as we think about this more, that that becomes kind of the standard and not something that we have to kind of push and advocate for, both on the patient as well as the provider side.